Okay. Okay, so good afternoon, everybody. Thank you for joining this webinar on cryoablation in early stage breast cancer. First of all, I would like to thank Boston Scientific for organizing this event. My name is Eric de Kerviler. I'm an international radiologist and I work in St. Louis Hospital in Paris. And my two co-speakers will be Covadonga Martí and Ylenia Navarro. Covadonga is a breast surgeon. She works in Paz Hospital in Spain, in the north of Madrid. And Ylenia is a breast radiologist. She also works in Paz Hospital. Here is the agenda for today. I will briefly overview the evidence of breast cryoablation today. Then Covadonga will talk about de-escalation, and she will emphasize on how to move from surgery to cryoablation. Then Ylenia will present the experience of La Paz Hospital and how can you use cryoablation for breast cancer. And then we will have approximately 10-15 minutes of time to take questions from the audience, and we'll try to answer this question. And finally, we will finish by closing remarks. So what is the evidence of cryoablation today? So here are my conflict of interest. If we look at the current landscape of breast cancer treatment, breast cancer is still a health problem because we have approximately 2.3 million new cases per year. And interestingly, more than 50% of this breast cancer, and interestingly, and by chance, I would say, this breast cancer are diagnosed as stage TA. And for those who are not experts in breast cancer, T1 consists of tumor measuring less than 2 centimeters. And also interesting point is that more than 1/3 of these new cases occur in women or in women older than 70, so it's also an interesting point. The standard approach are currently surgery, radiation therapy, systemic therapy, and all these treatment, even if they are good, they have a significant impact on quality of life, and they have some other treatment concerns. And all these prestigious societies at the bottom of the slide, ASCO, ESMO, NCCN, they pay little attention to this particular population of elderly and frail patients.
Okay. Sorry for the interruption.
Okay, so I will be doing my part, and hopefully we have Dr. Kerviler back. So in this part, we'd like to move to a practical side of the cryoablation in breast cancer. And then we'll see the part of Dr. Kerviler and Dr. Martí to understand with the whole vision how cryoablation is changing this time in the management of breast cancer. So in La Paz Hospital, we started doing cryoablation in breast cancer in 2019. And so far, we have done more than 600 procedures. So here we'd like to share with all of you some of the technical aspects, our experience, and some of the outcomes in our patients. First of all, why do we prefer cryoablation among the other ablation techniques? In the breast, it is easier to organize and schedule because there's no need of sedation. We just use the same local anesthesia as in a regular breast biopsy. Also, it is a totally outpatient treatment. The patient goes home right after finishing the procedure. Also, there are no indication limits. There is no problem if we are close to the skin or the pectoral fascia. We can treat big lesions. We can control the process with real-time imaging with ultrasound because the ice ball is really well seen with this technique. And because all of these reasons, cryoablation can be easily repeated if necessary. In terms of the technique, again, we use ultrasound guide because the ice ball is really well seen, but also because it is the easiest approach for the breast. What we do first is choosing the most suitable needle according to the largest axis of the lesion we want to treat. Then we're going to infiltrate the local anesthesia, and we just use anesthesia in the needle entry site, just there. There is no, you don't need more than that, just in a regular breast biopsy. And then we will introduce the needle into the center of the lesion, as you can see in the pictures below, with a security margin of around 1 centimeter. And then we'll start the cryoablation. And it consists normally in 3 phases of 10 minutes each phase, and it is freezing, thawing, and freezing. And again, there are no indication limits if we are close to the skin or the pectoral fascia. If we are close to the pectoral, we do not do anything. There is no problem at all. And this is what we do if we are close to the skin. In one hand, as you can see in the left picture, we use a hot saline bag covered with a gauze, and we put it on the surface of the skin when we see it is turning white. And this way, it really recovers its normal color again very easily. And on the other hand, if you use Boston system, as you can see in the picture on the right, it allows you to lower the power of the ice as a percentage, which is a very useful tool for these cases. And with this too is enough. We do not do hydrodissection. Actually, we think it is not necessary for the breast. Regarding the indications for early breast cancer, this first group is going to be in practice the main one, and it is patients with early breast cancer with no axillary surgery indicated. This, in most cases, is going to be an elderly woman above 75, 80 years old. Some of these women are not candidates for surgery because of fragility or comorbidities, but also we have to think that some of these women may be in a very good condition, but you just simply want to avoid, or the families want to avoid the surgical room. And also in this group, we should be considering, and actually we have had some of these cases, women with another advanced malignancy, not in the breast, that in the meantime are diagnosed with early breast cancer. For these women, cryoablation is also a very good option because you can treat with cryo the breast tumor, avoiding them a more invasive treatment, and you can allow to keep the focus on the other advanced malignancy. And secondly, we will see how we can expand this indication in early breast cancer. And we're going to see it through one of our trials. And this is very important too, because probably it's going to be the near future, as we are going to see with Dr. Kerviler and Dr. Martí. So let's take a closer look on this first group. So here, this is going to be the best scenario. And all the women with breast cancer in early stage, hormone receptors positive, which actually is the most frequent subtype. So here what we do is a combined treatment that consists of hormonal therapy plus cryoablation plus ideally, if possible, radiotherapy, because at the end what we are doing is using cryoablation instead of surgery, and the rest of the treatment protocol is going to be the same. How do we do this combined treatment using hormonal therapy and cryoablation? We can do what we call primary cryoablation, meaning that we do first cryo and then start with hormonal therapy. Or we can do a secondary cryoablation. We normally do this in bigger lesions. We'll start with hormonal therapy to help decrease in size the tumor first, and then we do the cryo. And also we can do cryoablation after failure or resistance to treatment at any moment. We started in March 2019, and here we're presenting results for the first 160 procedures, because these are the cases that we've been able to analyze to date. Considering a follow-up of at least 1 year by that time, there were 102 cryoablations, and excluding deceased patients, there were 96 cryoablations performed in 80 patients. About histological types, the most frequent were infiltrating ductal carcinomas and subtype hormone receptors positive. And these are our results. Out of these 80 patients, there was no tumor left after the first cryoablation in 90% of the cases. There was only one patient, with a residual tumor, in which we did another cryoablation with no tumor left after that. and we had 7 patients with recurrences. And of course, we have to analyze this group because it is important to know what happened here. So here we see that we had 2 cases with no hormonal therapy because one was a triple negative and the other one was a patient that did not agree with the treatment. We have 2 cases non-adherent to hormonal therapy and 3 cases with failure of the neoadjuvant hormonal treatment. So we can see that probably failure or lack of response to hormonal treatment increased the probability of recurrence after the cryoablation. So this is why it is so important, this combined treatment using hormonal therapy and cryoablation together to ensure better results. In the 7 patients, we did a rescue cryoablation in 6 of them, with 4 having no tumor left after rescue cryoablation. And by that time, we were pending in 2 cases of a new cryo. And only there was 1 patient in which we could not do rescue cryoablation, and she underwent a mastectomy. So overall effectiveness, no tumor left after cryoablation in more than 96% of the cases. So this shows that cryoablation is a perfect treatment for this group of patients. Now let's see some very interesting cases. This was a 92-year-old woman with a 26 millimeters invasive ductal carcinoma in right breast, hormone receptors positive and negative axilla. Because of the size, we started with hormonal therapy first. And this is the evolution 8 months after of the hormonal therapy. You can see the lesion is smaller, now measuring 17 millimeters. So this was perfect moment to perform the cryoablation. This is the procedure. As you can see on the first picture, you can see the needle going through the center of the lesion. And in the pictures below, you can see the ice ball really well covering the whole lesion. And this is the evolution in ultrasound 6 months after. You can see fat necrosis changes, no vascular flow. And below, 12 months later, fibrosis, no vascular flow. And this is last control. That was 4 years after cryoablation. You can see on the left, fat necrosis in mammography and in ultrasound. And very important, we have contrast mammography in which we don't see any enhancement in the cryo bed. So this confirms an excellent evolution of this patient. As you can see, and if you compare the imaging, contrast mammography is the most important tool and the most useful tool for doing the follow-up of these patients because it gives you more easily information than ultrasound. Especially when you start doing cryoablation, the changes on imaging in ultrasound are not that easy to understand. So contrast mammography is easier. Next case is an 89-year-old woman with a 34 millimeters invasive ductal carcinoma in left breast, hormone receptors positive and negative axilla. Here again, because of the size, we decided to start with hormonal therapy. And this is the evolution 6 months after. You can see the lesion is smaller, measuring 23 millimeters. So we decided to perform the cryoablation. Again, the same procedure and the same protocol as the previous case. This is the evolution 6 months after. Again, fat necrosis, no vascular flow. Forward 12 months and 18 months, fat necrosis, some changes of fibrosis, no vascular flow. And 2 years later, you can see in mammography, fat necrosis changes in the cryo bed. But again, very important, we have contrast mammography confirming there is no enhancement, so no tumor left, no recurrence. So an excellent evolution of this patient. So these are our follow-up recommendations. It is going to depend whether you have contrast mammography or don't. If you have it, we recommend to do contrast mammography 6 months after cryoablation. Then you can do another one 1 year later. And if it is a low-grade hormone receptors positive with a very good evolution, then you can do yearly controls with simple mammography and ultrasound if you like. But you must take this into account. You must do a closer follow-up in bigger lesions, high grade and resistant to hormonal treatment or triple negatives, because here you need to assess a possible residual tumor and, of course, recurrences. So here we normally do follow-up after 6 months, in some cases 3 months. It depends on the case. Of course, if you have any doubt, you can always do a biopsy. If it is positive, you can consider doing another cryoablation depending on the case. And if it is negative, you can continue regular follow-up. So now moving on to one of our trials, we are going to see some of the evidence we have so far with Dr. Kerviler and Dr. Martí, like ICE3 trial and FROST. They're going to explain all of that after this presentation. So in our hospital, considering all that evidence and our own experience so far, we decided to start a study, a similar study in our hospital. So it is a trial led by our colleague, Dr. Navarro. This is the article with preliminary results, and she's planning to publish the final article with all the patients included. So what we did here was we treated with cryoablation early breast cancer in selected patients. After that, these patients underwent surgery, and our aim was to prove that there was no infiltrating tumor left in the surgical specimen. These were the inclusion criteria. We included unifocal lesions, less than 20 millimeters in size, luminal A or V, HER2 negative and negative axilla, candidates for conservative surgery, and this is very important. We did not include extensive intraductal component, which we saw with MRI, because as you know, intraductal component makes the real size and extension of the tumor less clear, so this could lead to a failure of the cryoablation. Final results are with 92 patients. We finished this study in April 2024. Here representing preliminary results until April 2023 with 52 cases. All of them were infiltrating ductal carcinomas, with 32 being pure, meaning no intraductal component associated, and 20 being mixed, meaning intraductal component associated. And these are our results. Out of these 52 cases, there was no tumor left, no infiltrating component left in all the cases of the pure carcinomas. And there were 4 cases of infiltrating tumor left in the group of pure carcinomas. So again, we have to see, to study what happened in this group. And we think, again, it is because of the intraductal component that makes the real extension of the tumor not that clear. So that's why we recommend, if you have a lesion with intraductal component, we recommend to broadly cover the size of the tumor, to use a needle that broadly covers the whole tumor, and the size ideally estimated by ultrasound and also MRI. So as take-home messages, we have seen that cryoablation allows morbidity-free management of early-stage breast cancer, and together with hormonal therapy and, if possible, radiotherapy, constitute an effective combined treatment. You must remember, this is very important, in hormone receptors negative and resistance to hormonal treatment, you must do a closer and continuous follow-up to assess relapses. And it also may be an equally safe alternative to conservative surgery in low-risk breast cancer in selected patients. Thank you very much. So
thank you, Ylenia. Do you hear me now?
Yes, we
You
can
hear me?
hear you.
Okay, perfect. Can you stop sharing your screen? I
Yeah.
will try to take over, and I think
Yeah.
the rest of the webinar will be uneventful. I'm sharing my screen. And now. Okay. Do you see my screen? Are you okay? Do you see my screen? Are you able to see my screen?
Now we can see it, Eric. Thank you.
Yes.
Okay. Okay, so we will continue where we stopped. Unfortunately, we have a technical issue. So wait, just to remind you that we, if we go back to my the beginning of my presentation, we had three era in the de-escalation spectrum of breast cancer management. The era one, there's the era of radical mastectomy. Then we moved to a lumpectomy and sentinel lymph node biopsy. It was era number 2 with de-escalation, a very good survival and improved cosmesis. And now we are moving to the era of ablation. When we look at the current standard of care, where are we good and what works well? I would say almost everything works well. Screening and diagnosis allows an earlier diagnosis through screening. Surgery, lumpectomy or mastectomy allows personalized treatment approaches. Radiation therapy is a very good adjunction and ensure high local control rates. Systemic therapies also reduce treatment intensity in selected patients. We have overall excellent outcome for many patients with improved quality of life. So I would say that breast cancer outcome have never been better. However, there are still remaining gaps and unmet needs, and we should explore new local therapies. Why? Because surgical morbidity still exists. We have more and more old and frail patients that can be undertreated and overtreated. So clearly that's a major issue in the management of this cancer. We have some cosmetic cancers. We have also patient looking on internet and asking many questions and requiring less invasive option. And also another important thing, maybe we will have time to address this point at the end of the webinar. What means old? What means frail? We see in that in Ylenia presentation that they started a new study with patients older than 50. Is 50 old? Is 50 young? That's another story. But the question today is, can we treat safely selected breast cancer without surgery? And when it comes to talk about treatment avoiding surgery, we need to investigate the different ablative modalities. And if we look at the literature, we have 3 major modalities that have been tested in different papers: cryo, RFA, and microwave. There are some others, but with less publication. And I picked up 2 important papers in the literature. The first one is a review published in Lancet Oncology 2 years ago, and they compared all these techniques. And of course, we have less publication for cryo, but they are more recent than for RFA. And in this meta-analysis, cryo showed a superior long-term outcome, better visualization of what we are doing during the procedure, as the Ylenia showed you, and lower complication rate. And to my opinion, the most interesting paper is the second one, is the TERMAC phase 2 trial. They investigated different ablative techniques in a randomized manner, and patients were ablated, and then the tumors were resected. And then they compared the results of ablation. And in this paper, they concluded that cryoablation achieves the highest complete ablation rate with the lowest complication rate. So clearly, the green light is in favor of cryo. If you type cryo on PubMed, you will see 3 different settings, 3 different pathways. The first one, pathway A, is the one we are interested today, is a early stage, low risk breast cancer, and the objective is to eradicate the tumor without a surgical excision. Pathway B and C are palliative setting and benign disease. That's not the purpose of our webinar today. If we look at the literature, but Ylenia already mentioned this paper. The 2 major papers published recently were ICE3 and Frost, and they showed that the ipsilateral breast tumor recurrence was around 4% at 5 or 6 years. And with treated patient older than 60 or 50, depending on the study, and measuring less than 2 centimeters, that means T1 tumors. So these results are very encouraging and open the gate for ablative techniques. First of all, before ablation, of course, you should do a biopsy, which gives you the hormone receptor status, which can be an adjunction to the ablative treatment. And these results were on the basis of what is published, DCIS and luminal the invasive ductal carcinoma is the best candidate for ablation. Important thing to know is that cryo is ultrasound guided, so the tumor must be visible at ultrasound. It works as a freezing and thawing cycle. This causes tumor necrosis, and the advantage, as Ylenia told you, is that these procedures are very well tolerated. They can be done under local anesthesia. They can be done on an outpatient basis with excellent cosmetic results. And of course, additionally, there is an immunogenic potential of cryo. I entitled this slide my first cryo case. It was not exactly the first, one of my 5 first cryo case, but it's a very good example of what you should do for those who want to start with cryo. First, you should select a patient who is a poor candidate for surgery. This patient has a severe heart failure, and she was 87-year-old. There was a small tumor, a 16-millimeter invasive ductal carcinoma, and you see that you nicely see it at MRI, you nicely see it at ultrasound, and it's very important you see the margin so you know exactly where to place your probes. This is how we take our landmarks. In our experience, we draw some lines on skin to know the direction of the cryo probes. We do local anesthesia, as Ylenia showed you, exactly the same way as if you were doing a breast biopsy. And then, of course, you test your cryo probes, and you do, I like very much the transverse plane that shows you the distribution of the probes relative to the tumor. And at the beginning of our experience, we did the procedure in our CT room, and we control with CT, but it was just at the beginning because we had a huge experience with renal cryo, and we wanted to see if we were able to see exactly the same thing as in the kidney. But honestly, CT is not useful at all. The procedure can be done only under ultrasound guidance. This is what, as Ylenia showed you, what happens when you start freezing. The ice ball forms, and we have 3 ice balls coming from the 3 cryo probes, and these 3 ice balls merge. And then you create a big ice ball, it's growing up, and you see that the problem is that the ice ball is getting closer to the skin here. So just the thing that you can do is just with using a small needle, you can inject saline here, and you see that you can increase the distance between the skin and the ice ball, and then you can protect the skin. So it's very, very useful. And then this is the patient at the end of the procedure. The patient is really happy. Just to show you what remains of the procedure, some redness in the breast because we injected some saline and we performed some massage of the breast, but only 3 small dots in the medial aspect of medial to the nipple. So it's no scar. It's very, very important for these old patients. Patient, of course, was home the same day with excellent cosmetic results and no recurrence. So just before I give the floor to Covadonga to summarize cryoablation versus surgery, clearly surgery is in vast majority of cases an inpatient procedure, whereas cryo is 100% of cases an outpatient. Surgery is done under sedation or general anesthesia, whereas ablation is done under local anesthesia. And surgical incision is needed for a surgery, whereas we just have small puncture sites for cryoablation. So with that, I thank you for your attention, and I will stop sharing and give the floor to Covadonga, and that's it.
Okay, so
now you can share your presentation, Covadonga.
I'll try. So can you see my screen?
Yes. Can you also turn on your camera?
Sure.
Thank you.
Sorry about that.
Hi there. Hello, everyone. Is everything all right?
Yep.
So, hello to everyone. Good afternoon. First of all, I would like to thanks, of course, Boston Scientific. And I would like to start with some disclosures. And just to make things clear, I'm a breast surgeon and I love surgery. But I believe also in other less invasive alternatives. And as Dr. Kerviler already mentioned, in the past 130 years, breast cancer treatment has evolved from highly aggressive surgery to increasingly precise biology-driven therapies. Advances including breast cancer conserving surgery, adjuvant systemic therapy, targeted agents, and modern precision medicine have pushed 5-year survival above 90%. So what was once a uniformly lethal disease is now one in which most patients are cured. Remarkably, the most significant advances have occurred over the past 3 decades, during which breast cancer treatment has progressed from a uniform surgery-based approach to truly molecularly tailored precision treatments. Also, there have been some changes in surgical approach, and the principal objective is achieving equivalent oncologic outcomes with less extensive procedures, therefore reducing morbidity, particularly lymphedema and arm pain and restricted mobility, without compromising survival. This de-escalation spans 3 domains: the breast, the axilla, and the emerging frontier of surgery omission. Regarding breast surgery, we have witnessed a great de-escalation. It all started with breast conserving surgery, as demonstrated by Veronesi in the Milan trial. Later on, the use of neoadjuvant systemic therapies and the implementation of oncoplastic techniques have also improved the chances of getting a breast conservation. But the possibility of omitting surgery is a very promising option, in which not only percutaneous ablation is on the table, but also the possibility of vacuum-assisted biopsy or electroporation in different breast cancer settings. On the other hand, axillary surgery in breast cancer has also been de-escalated, and we have gone from radical lymphadenectomy to sentinel lymph node biopsy, reducing morbidity. Then the ACOSO Z11 trial also demonstrated that omission of axillary dissection was safe even with 1 to 2 positive sentinel lymph nodes. And later on, other trials like I-SPY2 trial, OPBC-07 trial, have also considered the possibility of de-escalation in those cases that go from CN positive to N0 axillary setting after neoadjuvant treatments. And very lately, there are 2 very important trials regarding the omission of nodal staging in those cases with very good perspectives because of the in favorable cases with HR positive small tumors. There are SOUND trial and INSEMA trial. And this consideration has also been reported in the NCCN 2026 guidelines. So I think we are living a very important scenario in which we can go very far with breast cancer surgery de-escalation. As I already mentioned, the results of SOUND and INSEMA trial demonstrating the oncological safety of omitting axillary staging And also the results, as Dr. Kerviler mentioned, of the FROST and ICE3 trials mean that all these together show that de-escalation is no longer a future goal, but it may be a present reality. It's very important to choose the ideal candidate. Already Dr. Navarro and Dr. Kerviler have talked about this, but I would like to precise a little bit more. We already mentioned these very important trials regarding cryoablation, but I think we also have to mention the Raffaello trial that considered radiofrequency. The very important thing about Raffaello trial is that is a phase 3 trial, whereas I3 and FROST trials are phase 2 studies. But they share a lot of things in common. I3 and FROST trial only consider invasive ductal carcinoma patients, whereas Raffaello trial also included DCIS. But the three of them consider small tumors under 50 millimeters, while FROST trial under 2 centimeters, N0 tumors, negative axilla, and unifocal tumors, which were visible with ultrasound. But the important difference among them was the use of adjuvant therapies after ablation. Radiotherapy was mandatory after Raffaello trial, after the radiofrequency study, but only partially given in the cryoablation studies. More or less the same with endocrine therapy, which was given after, as per standard of care after radiofrequency, but only recommended in the I3 and not given in 100% of the FROST trial patients. And this might be an explanation of the slightly worse results regarding a 5-year ipsilateral breast tumor rate in the cryoablation trials. Well, currently, and this is a very important point, no major international clinical guidelines includes percutaneous ablation as a standard of care alternative to breast conserving surgery. But it's remarkable that the Japan public health system has already considered radiofrequency as an alternative to surgery in those breast cancers under 50 millimeters. And also, that cryoablation has been approved for benign lesion treatment by FDA in the United States. And yes, although clinical guidelines do not yet endorse these techniques, in 2024, this interesting policy review was published in the Lancet Oncology. The authors consider the use of percutaneous ablation in cases of small tumors under 1 centimeter, luminal A subtype, and after reaching a shared decision with the patient, also giving standard adjuvant treatment. This paper also raises the future possibility of applying these procedures in other settings, as in the post-neoadjuvant scenario. So, the safest selection criteria would be a postmenopausal woman with a small tumor under 50 millimeters, non-lobular, this is very important, only invasive ductal carcinoma with a very CDIS component, a small CDIS component, HR positive, HER2 negative, ideally luminal A-like, unifocal, visible by ultrasound, with a negative axilla, and always considering adjuvant treatments as a standard of care, as we would do if this patient would have undergone surgery. But as already, Dr. Kerviler already mentioned, the ideal patient to start with is an old or frail or non-surgical candidate because she has another tumor, whatever the circumstances, with a small unifocal negative axilla tumor, HR positive, HER2 negative, combined with adjuvant standard treatments as endocrine and radiotherapy. And also, I think it's important to remark that this official statement by the American Society of Breast Surgeons has been published this year, in which they consider cryoablation of malignant tumors of the breast in patients over 70 years old with a favorable characteristics, as we already mentioned. As it happens with breast cancer in general, cryoablation should be delivered within a multidisciplinary care pathway, where breast radiologists, breast surgeons, pathologists, radiation oncologists, and breast care nurses each play complementary roles throughout patient selection, treatment, and also follow-up. And this is how we do it. Currently, due to the absence of phase 3 trials, we only consider cryoablation in frail patients or when there is a surgery refusal. Usually, we take into account, as we already spoke about, a small HR-positive, HER2-negative tumors with a negative axilla, but in selected cases, other tumors can be also considered. If we think it's a good case for cryoablation, we discuss it in the multidisciplinary tumor board. And if the patient has the okay for cryoablation, we speak to our radiologist and cryoablation is performed. Later on, we consider adjuvant therapy. In the case of endocrine therapy, sometimes, in most cases of HR-positive tumors, we start endocrine therapy as soon as we have the diagnosis, as we confirm this is an HR-positive tumor. But we consider later, after the cryoablation, the possibility of radiotherapy, depending on the case, also the age of the patient. But if we can, we also give radiotherapy. And after this, we start follow-up. As Dr. Navarro already told us, we have a follow-up with image techniques, either enhanced mammogram or ultrasound every other 3 to 6 months. We combine this with also a clinical follow-up. And to conclude, we think cryoablation is a safe and effective technique that may serve as an alternative to surgery for selected patients with small breast tumors. Adjuvant therapy should be administered according to the standard of care to minimize the risk of recurrence. Of course, a multidisciplinary approach is always recommended. And unfortunately, until its inclusion in clinical guidelines, its use should be limited to patients who are not candidates or refuse surgery. Thank you very much.
Well, thank you, Covadonga. Can you please stop sharing your presentation? I will share mine. And okay, are you able to see my screen?
Not yet.
Yes, no.
Not yet. And now?
Yes,
No, yeah.
Okay, so now it's time to move to Q&A. So I already have some questions from the attendees. A question about indication of radiation therapy after combined cryo and endocrine therapy. Maybe Ylenia or Covadonga, any of you?
Yeah, I think, well, it's a very, very interesting question because it's very controversial, especially in very elderly patients, in which, many authors consider that if you give endocrine therapy, you can not give radiotherapy, and the other way around. I mean, if you give radiotherapy, you may avoid endocrine therapy. So it depends on the case. What we have to consider is that we should do the same thing as if the patient would undergo surgery. I mean, if it's an elderly patient that we would operate, would we give her radiotherapy? In that case, we should do it the same way after a cryoablation. If we would not give her radiotherapy, then the same thing. I mean, cryo is equivalent to surgery, and that's how we have to manage this.
Okay, I have another question for you, Covadonga. I'm sorry, but the questions are targeted to you. What future indication do you see for cryoablation? Does it have a role in non-luminal breast tumors? For instance, triple negative or whatever, something like this.
Well, I think we will get there. Maybe it's a little bit early to standardize this, but we will get there. I'm sure of it. I mean, and well, as Dr. Navarro, as Ylenia already told us, we have performed some of these cases at our facility in La Paz Hospital. And we have well, some cases with good results, some others that have progressed. But I mean, I think in very selected cases, we can achieve very good results. And probably the immune response that cryoablation can get. We have not spoken about this because it's a very broad area, but I think this will be also a thing to take into account in the future. I think we will get there in small tumors, triple negative tumors, HER2 positive tumors. Cryo will be there. Not now, but we will get there, I'm sure.
Okay, I've got another question. This question is probably more for Ylenia. What about cryoablation of cryoablation of metastatic node possible? Personally, I've done it twice, but I would like to have your views, and people who ask this question probably want to know your answers as well.
Yeah, we have technically it's perfectly possible. We have done that, I think, like in 10 patients, I think. And technically it's the same as in the breast. We normally use, because lymph nodes are not that big normally, so we normally, with Boston system, we use ICID, which is the needle that makes the smallest ice ball.
The one.
But you have to be careful with the nerves, with the plexus, because you're not seeing them with ultrasound, of course. So what we do is during the procedure, we are always telling the patient to move her hand and to open and close the fist to see if she has some tingling, feeling, or some pain. So if she feels anything, we stop the procedure. That sometimes happens. And normally we do shorter phases, and with that it is enough.
Okay, excellent. I have another question. Could cryoablation be used after a good response to a neoadjuvant therapy? Maybe Covadonga, you can answer this question.
Yeah, I think I'm unsure about it. In these cases that we are operating after neoadjuvant therapy, especially triple negatives, HER2 positive pure tumors, that in the MRI they have a radiology complete response, that when we operate them, there's no tumor left. I mean, in those cases, I think that could be an option. Obviously, the problem is we wouldn't get a pathologic result, but maybe we could perform a biopsy, and if we get a negative result in a biopsy after neoadjuvant treatment, and the biopsy is negative, probably a cryoablation of the tumor bed would be clearly enough, and avoiding this breast surgery.
Okay, I have another question. Maybe this question is more from Ylenia. Ylenia, how do you interpret follow-up imaging, and what findings make you suspect residual disease? And I would complete this question by asking, do you always perform contrast-resonance mammography, or do you prefer MRI? So what findings are suspicious after ablation?
Yeah. Okay, so first question, as I've explained before, is going to depend whether you have contrast mammography or don't. If you have contrast mammography, the follow-up, how to interpret the changes is really easy, because the contrast gives you the information. As the cases I've showed, you do the contrast mammography, you don't have any enhancement, so you can be very sure that there's no residual tumor and no recurrence. So the problem is if you don't have contrast mammography and you're starting doing cryoablation, the changes on ultrasound are sometimes not that easy to understand, and especially when you start doing this. So actually, when we started doing cryoablation, that was 7 years ago, we have no evidence of anything. So we saw this imaging in ultrasound and we didn't actually know what were happening there. So we always did a biopsy with the first cases. I think during the first year that we were doing cryo. So maybe you need that evidence to prove to yourself and to your colleagues that cryo works. And with ultrasound, you can do follow-up every 6 months, like with contrast mammography. And of course, if you have any doubt, as I explained before, you can do a biopsy. And the answer to your question, what was your question? Sorry.
I had a small additional question about MRI or contrast mammography. If you dispose from MRI.
The thing is, here we're talking about elderly patients, so we prefer not to do MRI because some of them are fragile, or so. And contrast mammography is perfect imaging test for these patients. So with that, for us, it's enough. Yeah.
Okay, and one small question for Covadonga. Can you share your personal experience by telling us an emotional story of one of your patients? I know most of these patients are very emotional because they are old, and sometimes you have, I'm sure, Covadonga, you have something to tell us.
Yeah, sure. I mean, well, several cases come to my mind, but maybe one has been very, very special. And it's not an old woman because she was like in her early 50s. She was a patient with a very advanced lymphoma. And during a staging study, I don't know, with a PET-TC, I think a couple of suspicious nodules were seen in both her breasts. So a biopsy was performed, and the biopsy confirmed bilateral breast cancer. So we took the case to the committee because she couldn't get any more radiation because she had get radiated because of her lymphoma. The tumor decided to perform a bilateral mastectomy. And I really couldn't tell her this decision. Well, it was hard. I finally told her this, but it was hard for me to tell her that she had two very small tumors in both her breasts, and she was being treated for her lymphoma with chemo. And besides this, she had to undergo a bilateral mastectomy. So I really couldn't tell her this. Well, I was trying to explain this very hard decision. And while I was saying this, I don't know why I mentioned the possibility of endocrine therapy and cryoablation. And she opened her eyes really, really widely. And she said, "Tell me more about this." So I explained this. I told her that was kind of experimental, mostly in a woman her age, but that it worked very well in elderly patients. And she said, "I want this. I don't want to undergo surgery. I want this." So we started with endocrine therapy. In one side, the tumor disappeared with endocrine therapy, and the other tumor reduced its size, and she underwent cryoablation of both the sides. In the left side where the tumor had disappeared, well, the tumor bed, the residual tumor bed was cryoablated, and she is free from disease in the breast. It has been like 2.5 years from now. So she's really happy. She's very happy of cryoablation. She's very grateful. And well, I don't know. It's a very important patient in my professional life. What can I say?
Yes, it's a very nice story. I think it's time to move on. I will try to move and closing remarks now, and we do these closing remarks along with another question for everybody. I think that everybody will agree with that. The sweet spot for curative intent in this patient is this biological profile, HER2 negative, hormone receptor positive, luminal A, luminal B, tumor size 1.5 or 2 centimeter, let's say T1. Morphology, I think everybody would agree with unifocal IDC with less than 25% intraductal, and keep in mind nodal status negative, even though we can treat some, but keep in mind nodal status negative. My main question is we were at the beginning of the presentation, we were dealing with the age of the patients. Every time we say, okay, cryo for old patient, frail patient, but what means old? What means frail? And I3 and Fro study, it was patient above 50, above 60. Is it for you a definition of an old patient? One of you mentioned the age of 70. Personally, in my experience, my patients are more around 80 or something like this. Ylenia and Covadonga, what are your views? Is it better to talk about to think in more in terms of age or in terms of comorbidities?
I think, well, I mean, the age is an imaginary line nowadays, I think. But it's more of what the tumor board can approve. I mean, if it depended on me, but unfortunately, we don't work that way, and I think it's good that we don't work that way. But if we have to stick to what guidelines say, we can't consider this in younger patients. But if it was for me, I would consider it for any woman with a good prognosis case and a small axillary negative tumor. I mean, but in terms of not being controversial or I mean, not getting into trouble or legal trouble, I think nowadays we are limited to over 75, 80-year-old patient, or in those cases, as we already commented, with patients that are dealing with some other more important diseases or more aggressive diseases that are more producing more trouble for them. I don't know, but it's not because of the efficacy of the treatment or because we don't consider it works. It works in all patients. But I mean, nowadays, in order to be more conservative, we have to stick to these over 80-year-old patients, I think.
Okay, it's important. I think as soon as you get visible by communicating in the mainstream press, giving interviews, and being visible on internet, when people know that you are doing cryo in the breast, and we get contacted by people directly sending us emails, and sometimes we see ladies not older than 40 and telling, okay, I have a breast cancer and I want it to be ablated. Please ablate it. I don't want to undergo surgery. So it's a real problem.
Yeah, it will be because if the patient denies the surgery option, you can offer it to her. I mean, in those cases, we have done. I remember another case with she was an HIV positive woman, and she didn't want surgery at all. She agreed to start endocrine therapy, but she didn't want to go through surgery. And well, she responded well to the endocrine therapy, but because of the risk of endocrine resistance, we insisted, and finally she agreed to undergo a cryoablation, and she's doing very well. But I mean, in these cases in which the patient doesn't consent to go through surgery, yes, I think we can offer this, and we can offer this I mean, with a quiet conscience. I'm not worried if this patient doesn't go through surgery.
Okay, but the problem is that if the treatment fails, we are clearly out of the recommendation. So if the patient complain, who will be responsible?
Well,
as the patient?
we have to make clear that this is out of the guidelines nowadays. If she asks for it, we have to tell what we have now, that we think it works, but we have to still get the approval of the international guidelines. And if she insists and she denies the possibility, well, she has to sign an informed consent. That she's going through this.
Okay, I fully agree. So I will just move to the next slide. Here it is. So I think it's my last slide. So I think that everybody will agree that patients treated with cryo have a low recurrence. Therapy should be tailored to tumor biology and patient profile. So frail patient, old patient, and good invasive ductal carcinoma profile, small tumor, no lymph nodes again. And clearly, the escalation is the future, and probably in the future we will share not the market, but we will offer the best therapeutic option to our patient. However, as Covadonga said, additional evidence is required before ablation can be included in clinical practice guidelines. And with that, I think we are finished. So I would like to thank everybody. Thank you, Ylenia. Thank you, Covadonga. Thank you again for Boston Scientific for supporting this event, and thank you to all the attendees of this webinar. I think it was a very interesting webinar with nice material. Sorry again for the small technical issues we had, but we had the webinar put in the reverse order, but in the end we made it. So again, thank you everybody for being flexible, and I wish you a nice evening. Goodbye.
Thank you.
Bye-bye.
Bye.
Bye-bye.